going through basically what we do with our anesthetic equipment and monitoring. Okay. So what we're going to be doing in this presentation, we're first going to review the minimum recommendations for, kind of monitoring anesthetized patients. We'll then spend the remaining time to go over the various forms of monitoring equipment that we have. We'll discuss a little bit of the basic technology, the parameters that can be measured, as well as the limitations and a lot of the common kind of problems and errors that we seem to experience when we're using these types of equipment. For your reference, I'm also going to include some of the approximate costs for some of these devices that we'll show. All right, so anesthetic safety has really come a long way over the course of these past few decades. And so veterinary species still do happen to experience some of the highest anesthetic mortality that we have. Even though things have improved in recent years, we still do have fairly, elevated risk in comparison to human general anesthetic mortality. And certainly among sick patients, that mortality rate becomes even higher, as you can see with our, ASA 3 or more patient mortality rate tends to run probably about 1.3 to 1.4%. But other than death, there can still be other consequences to poor anesthetic monitoring. And so we could, see issues such as worsening of renal or cardiac disease, GI issues, or even the development of chronic pain in some of these animals. While we don't have a lot of statistics on the occurrence of these other long-term consequences, we still want to attempt to mitigate them as good as possible. The ACVAA and AHA organizations have published guidelines and recommendations for their patient monitoring and anesthetic supportive care at their websites. And so all of you, I would encourage to go to these websites and review these published documents, as they will be able to kind of flesh out a lot of the details on some of the things that I can only briefly cover tonight. And AHA's guidelines are the most recent, and they do have, very nice diagrams and details on local anesthetic techniques, as well as ways to manage patients under anesthesia that may be having complications. So there's a lot of good references included in that document. We'll start with the ACVAA requirements, and these are considered to be the minimum standards that should be monitored for patients that are under general anesthesia in order to, keep them as safe as possible. So first is circulation, in which we should kind of keep in mind a continuous assessment of a patient's heart rate, its pulse and perfusion quality. Next is oxygenation. Next is ventilation, and then finally temperature monitoring. The AHA recommendations, which kind of show that it's a little bit of a collaborative effort between several, anesthesiologists, as well as other kind of veterinary practitioners and technicians as well. They're basically fairly similar in that we do want to monitor, patients' respiratory function, cardiovascular function, cardiac rhythm, monitoring their normal body temperature, as well as trying to continue all of that monitoring also into the recovery period, which can be one of the, highest risk periods during an anesthetic patient's, experience. Recovery is still quite important. So let's start with the ways that we monitor circulation. One of the things I wanted to say was that I'm going to be displaying several different models and pieces of equipment in this presentation, but they are all for example purposes. I'm really not intending to, promote any company's products or anything like that. These are just pieces of equipment that, you know, I have happened to use, or that we're just displaying the variety of things that are out there, and some of the pieces of equipment that you guys may have in your hospitals as well. So probably one of the most important pieces of monitoring equipment that we've been using throughout you know, the years of veterinary medicine is the electrocardiogram. It is one of the oldest, and it's been used in veterinary science for probably almost a century. Thankfully, you know, our modern equivalent is much more portable and user-friendly. As you saw in the previous slide, we certainly don't have to dip our patients' limbs into an electrolyte solution anymore. I think all of us can appreciate not having to do that. So most of these ECGs are now often combined into a multi-parameter monitor. They have several different systems that are included into the same unit, which is very convenient. There are also wireless Bluetooth and remote systems that have become quite popular, and these can also allow you to record and even send your ECG images as well. They can range in cost anywhere from less than $100 to, you know, the higher end of the range there is probably your, you know, your high-end multi-parameter monitor in the, you know, several thousands of dollars. Probably just an ECG alone unit, you know, maybe reasonable moderate costs there. The actual function of the ECG is to provide a real-time assessment of the cardiac rate and rhythm of your patient. And anyone who's monitoring can immediately detect any sort of change in that cardiac electrical pattern as you're monitoring your patient. And the other, you know, importance of this unit is basically noting changes and trends as that patient goes through the process of anesthesia. Certain drugs that we use, you know, they may induce changes in that cardiac rhythm, or an animal just may simply not have had an issue detected prior to it going under anesthesia. Anesthesia likes to uncover a lot of underlying issues that we don't always see in that patient beforehand. We also use the ECG to kind of monitor and detect extra cardiac issues. So electrolyte abnormalities, hypoxemia, things like that can occur, you know, due to the patient's issues. And, you know, some of those issues can result in pretty fatal outcomes. And so we want to be able to note those types of things immediately. So artifacts can occur in the ECG, and a lot of this can be due to electrical interference. Sources of that electrical interference could include things like cautery, nerve stimulators, bear huggers, or other heating devices. They can also occur due to just, you know, a lot of electromagnetic equipment or nearby things that, you know, even cell phones in some cases probably. The person who's interpreting that ECG must be skilled enough to, you know, be able to determine whether something is an artifact versus a real issue. And, you know, they also probably need to have the judgment to be able to recognize when you have a displayed number, which is often, you know, shown on most multi-parameter ECG units. There is a displayed number on there, but that's not always in line with reality. So the person who's watching really does need to kind of pay attention to be able to differentiate when something is real. One of the most severe examples of this is when there is a complete dissociation between the cardiac electrical activity and its contractility. And this is also known as pulseless electrical activity, or PEA. This can look anywhere from just slightly abnormal in the ECG, like a person who's been doing this for many years may just detect kind of a subtle change in the way that the ECG rhythm looks, or it can look, you know, completely normal. So it looks like a normal sinus rhythm. It's been just trucking along. completely. Meanwhile, the animal may have been dead for several minutes or so. So it is very important that we use other parameters other than just an ECG to be able to determine, how that animal's status is. And it seems unlikely, but it definitely does occur. So another means for monitoring circulation and pulse is the Doppler flow detector. And this is a unit that converts ultrasound into an audible signal. It's composed of a flat probe with two crystals that are embedded in epoxy. One of those crystals is a transmitter while the other is a receiver. And the base has a rechargeable battery. Usually this makes it pretty handy to be a portable unit that can travel with an animal if it needs to kind of move around or be transported. Usually they are pretty reasonably inexpensive. Cuffs may need to be replaced on a fairly decent basis depending on how often they're used, because sometimes they can develop some leaks and such. But otherwise, it's a pretty reliable piece of equipment, and they probably can be used across species for the most part. Dogs, cats, very common for use in exotics, larger animals as well. They can be typically used on peripheral limbs. The tail works as well. So the benefits of the Doppler are that it's a very non-invasive and a reliable way to have a continuous pulse rate. Or generally in the small exotic species, you can also apply it as a heart rate monitor. It does provide an opportunity to detect any infrequent or subtle arrhythmias. So as an audible signal, you can, be doing other things while you listen to that animal's pulse going. And the nice thing about a Doppler is there is no mistaking that that is a pulse that is related to an active, and, appropriate heart rate. There's not going to be something else that causes that sound. So it is something that can be applied pre-anesthetically, and it can also travel with the animal through the perioperative period. You can use it through to the recovery period. And it gives you this kind of continuity of measurement, so that you have the same method of measurement going with that same animal throughout its anesthetic period. You can use it to check blood pressure intermittently by using a sphygmomanometer. And when it's placed peripherally, you can use it to provide kind of a relative indication of blood pressure, which is something we'll discuss in the next few slides, which you can use to use for trends. Because of the way the Doppler works, the use of certain classes of drugs could affect the sound quality of the pulse. And most notably, this occurs with dexmedetomidine. So often, if you have the Doppler on prior to a dose of dexmedetomidine, the pulse may increase in intensity, but more often than not, it actually decreases in intensity. And that's because that pulse sound that is being generated, as well as if you palpate a pulse, the feeling and the sound are generated by the difference between the systolic and diastolic pressures. And so some of these drugs end up bringing those two values closer together. So while we know that dexmedetomidine causes vasoconstriction and a rise in blood pressure generally, because the systolic and diastolic pressures start to get closer together to each other, that pulse quality often becomes more poor to palpate or to listen to. Usually the effect is short-lived, but it kind of depends on the dexmedetomidine dose. And so it may return and it may sound great again, or, it may take a little bit of time to improve. It's also somewhat of an art to attach that probe to the animal. It has to be securely attached, but not too tight. Just the right amount of gel. Otherwise, sometimes it can slip right off. Another problem is that the box may actually pick up some radio frequency interference, and that can distort the sound, cause background static. Any damage to the crystals will also affect the sound quality of the Doppler. Needless to mention, you do have to use a limb which is perfused in order for it to work. Without an ECG, it's not really possible to determine if an arrhythmia that you hear audibly is either a sinus arrhythmia or if it's ventricular in origin. So if you are noticing that you have pulses that come prematurely, you can't necessarily localize whether that, may be a VPC or, just a sinus arrhythmia. So if you hear something on the Doppler, you do have to apply an ECG to really determine what's happening there. With blood pressure, it does have to be done manually. So somebody has to sit there and kind of inflate the sphygmomanometer and do it on a fairly frequent basis. In recent years, studies have been comparing Doppler measurements to invasive blood pressure with the finding that these values don't actually correspond to a systolic blood pressure. So historically in the past, we always thought of, what number that we obtain from the Doppler is always going to be a systolic blood pressure. That's not necessarily the case anymore, especially with our smaller patients. And also depending on what drugs they've. So another issue is that sometimes the Doppler does overestimate or underestimate blood pressure in the extremes of hypotension or hypertension. So it's a little bit, kind of not 100% accurate in terms of what number it is that you're getting, which we'll discuss a little bit more later. So one of these studies, was performed in anesthetized cats, and they compared that Doppler measurement with both the systolic and mean arterial pressures. And what they found was that basically the Doppler readings were about 9 millimeters of mercury below the actual systolic pressure that was obtained from the arterial line, and they were about 14 millimeters above the actual mean. And so, unfortunately, in this study, they found that there was so much variability among those cats that they anesthetized that they couldn't apply any sort of a correction factor. So we can't assign that Doppler value to a systolic, a diastolic, a mean. It's a number. It's probably somewhere between your systolic and mean, but it can't really be consistently applied to every cat. So in some cases, it may very well be the systolic. In other cases, it may not be. And so it's difficult to know exactly what that number means. The next method for measuring blood pressure is an oscillometric technique. And these can be standalone units or they can be included with other multi-parameter monitors. They detect the mean arterial pressure as the cuff deflates and you get the oscillations of blood flow in the artery. There are computer algorithms that work in the unit and they calculate the diastolic pressure and the systolic pressure back from the mean. And so the mean is typically the most accurate number on these types of machines. The nice thing about an oscillometric unit is that you can program it to make automatic measurements every few minutes. They're non-invasive, they're easy to operate, and they provide a digital readout that doesn't require a skilled person to, interpret. It spits out a number, that is the blood pressure. And so the cost of these units can range and vary depending on kind of their quality and the technology that's used within them. I'll say that I have kind of a cost in there, but in recent years, they are becoming a bit more expensive to deal with. Some of the technology has changed. There are a lot of companies who are making a lot of different monitors. And so, they may actually be getting a little bit more expensive than the kind of, the quotes that I was getting probably a year or so ago. So they may be a little bit more. Most of these veterinary designed monitors do provide a reasonably accurate mean arterial pressure for most dogs and cats. If your animals are normotensive, usually that systolic and diastolic is calculated relatively accurately. And in the example in the lower right corner, where you see that the purple waveform, where there's an arterial line that's side by side with a non-invasive unit, you can see that the numbers are actually matching pretty well. And so some of these units, do work quite well as far as estimating a good blood pressure. But again, sometimes that depends on whether the patient is already, very stable and is a good circulation. Most of the blood pressure monitors do include a heart rate where you can kind of look at what the heart rate it is detecting and then kind of gauge whether or not you choose to believe that blood pressure. If it captures an accurate heart rate, perhaps the pressure is real. One of the sources of issues with oscillometric monitors tends to be the setting of the interval between the readings. And if they're set too far apart, there can be really a significant delay in being able to detect a problem and then treat it and intervene for that animal. There's also the flip side of that, in that if the interval is set too frequently, you can also cause ischemia to that animal's limb because of the just constant squeezing of that cuff. And so you could potentially cut off a perfusion to that leg. So not only will the readings be off, but now you may actually be causing some issues to that animal if they're set too frequently. Typically, every 3 minutes is a setting that maintains the safety for the patient, that it continues, its leg can circulate, but it also allows that arterial pressure to just resume in between those readings, and so that you're getting a fairly accurate amount. And mostly every 3 minutes is safe enough for, a reasonable amount of monitoring of that blood pressure for most patients. There are also issues with the cuffs themselves, and many of these units were really not designed in mind of all of the different species and breeds and sizes and just, animals' conformations that we have to deal with. And so, when we try to position these cuffs and size them appropriately for the limb and for the animal, it's really not easy, especially with our friend over there on the right. They have impossible legs. They have no tail, and you're lucky if you can get anything to read on those. So it sometimes, I feel like some of these units work amazingly well, and we've certainly used oscillometric units on species like pigs and things with, skin that's 2 centimeters thick, and it gives a reading. And I am amazed by its ability to, be close to an arterial line at all. And I know that whoever designed these machines certainly didn't think that we'd be using them, on a pig or something, but somehow they work. So occasionally those algorithms are quite good. There is a lot of variability between different manufacturers and brands. And although the different companies have their own proprietary information, there is still a degree of inaccuracy amongst any unit at extremely high or low pressures, or when an animal has an arrhythmia. So all of those things tend to make it more difficult for these units to read accurately. Many recent studies that test different oscillometric units don't often meet the requirements for the ACVIM recommendations as far as how well they correlate with invasive blood pressures. And so, they try to test these out and get some kind of a standard. So some of them pass this test, some of them don't pass this test. It really is difficult to find consistent units that tend to work well. So finally, that brings us to direct blood pressure. An invasive measurement system is available on most of these multi-parameter monitors. There are also standalone units that just do arterial pressure, so you can kind of bring that in on the side and have it be a supplemental unit. They can measure systolic, diastolic, and mean pressures through an arterial catheter, and this is connected to a specialized transducer. The system does require a special cable and some, consumable items. as well as this high pressure non-compliant tubing. Usually they range in cost from, they may be included with a multi-monitor, or these are some estimates of, standalone stuff. Because of the consumables, there are some supplies that need to be replaced per patient. The direct blood pressure does provide a continuous display of a pulse rate. You can have a sense of the animal's rhythm. There's a systolic, a diastolic, and a mean arterial pressure that are very accurately displayed with these things. And once again, similar to how the Doppler, provides a pulse rate that can't be mistaken with anything else, when you have an arterial line, it will not be mistaken with anything else. So there is no real artifact with this type of monitoring. This is the gold standard for accuracy and beat by beat changes in blood pressure. You also are given a waveform with most monitors that shows you additional information, which you can use to guide treatment possibilities, including pulse pressure variability and vascular tone. And the arterial line itself does also provide you the opportunity to run a blood gas sample if that patient needs it. There are really not many sources of inaccuracies or limitations with this, in the sense that, you have to worry about what your readings are. But there is, the required skill of being able to place the intra-arterial catheter. Mostly this is a problem in our super tiny patients. So sometimes, again, those are the ones that we have the most difficulty measuring in the first place. So getting an arterial line in them is not the easiest thing either. Certainly that catheter may clot, air bubbles in the transducer and line may produce artifacts, and any cracks or leaks in the tubing could also produce some artifacts. So the main downside of this system is really only the labor and the just overall practice you need in being able to troubleshoot the system accurately. So, on a practical level, we obviously can't place arterial lines in every patient. And certainly that's not, what we are able to do in veterinary medicine, especially in a busy day with, hundreds of patients coming through. We can't put art lines in everybody. So, but knowing that there are all those discrepancies that I just, talked about with the other, non-invasive units, what do you do when you don't have an invasive blood pressure? So for one thing, we try to keep consistent with whatever method it is that you've chosen to start with to monitor the trend in that blood pressure. So getting a baseline blood pressure also, perhaps, if the patient is compliant when it's been pre-medicated, as it's sitting there, getting that initial baseline blood pressure and seeing what that is, and using that as a guide to trying to follow the trend in that patient throughout the procedure. Because different methods are not really interchangeable, there isn't a great correlation. It's best not to interchange your method between, in the middle of a procedure. So if you start with a Doppler, it's probably best to stick with that. Unless, of course, the exception being that your monitor just goes away, you just lose everything and you need to then switch methods to be able to measure something. But typically, if we have critical patients that we're concerned about, we can't get an art line, everybody tried, and we have, concerns about how it's going to do under anesthesia, sure, we will use oscillometric units, but sometimes we will supplement that with placing a Doppler on another limb and then getting a baseline idea of, okay, before everything goes crazy, let's see what the Doppler says, let's see what the oscillometric says, and then kind of try to get them to see if they see how they jive, if they do at all. But again, following the trend, what happens over time? Does it take a nosedive or does it stay pretty steady? Another way to manage the risk is to use a higher threshold with your patients that have other comorbidities. So if you know that, if you have a particularly sick patient that's going, maybe it's, just hypertensive to begin with, or it has some degree of kidney disease, you can use a map of 70 instead of allowing that patient to get to 60 or below before you intervene. And kind of finally, I would say that while blood pressure really is something that helps us to estimate the patient's kind of global cardiovascular status, it's not necessarily equivalent to cardiac output or tissue perfusion. So sometimes, we do have to look a little bit more globally at the patient and say, if there's an open laparotomy, have a look at the abdominal organs. Do they look pink? Do they look perfused? Those mesenteric arteries sometimes are a great visual, indication of, they pulse away, so sometimes you get a great look that, the GI tract is being well perfused. This is one of the shock organs for sure. So if there's not enough, circulation, often those will suffer. And so always have a look at those mucous membranes. End-tidal CO2, which we'll go into in a little bit, is also a good indicator of, indirectly of perfusion, as well as serum lactate. And so those are all kind of other things that you can look at and monitor to make sure that that patient, did have good perfusion. So we're going to move on to methods for monitoring oxygen. The most common of those is the pulse oximeter. And this does provide a simple, non-invasive monitor that displays the percent saturation of hemoglobin, and it also displays a pulse rate. They work rapidly with real-time information. There are several portable models as shown here on the side. They utilize one of two types of technology, either transmission or reflectance. And models that provide co-oximetry or plethysmograph capabilities tend to be on the higher end of this range. So you can certainly get, a pulse oximeter for a very reasonable price. You can also chip in a little bit higher for something that can give you a few more functions, as well as a waveform to it. The simplest pulse oxes just provide an SpO2 and pulse rate. It's somewhat similar to a Doppler in that you can kind of estimate a little bit of blood pressure if you decide to put your pulse oximeter onto, a distal toe with a blood pressure cuff proximal to it, and then deflate your cuff and watch as that pulse waveform returns. It's kind of crude, but if you have nothing else, then that can give you something in a pinch. Models with plethysmography, which is your waveform, image on the screen there, can give you a little bit of a similar pieces of information to a direct arterial waveform as well. Some also combine the SpO2 with capnography. Some of these known-ins have a little capnograph on the side. With SpO2, the pulse oximeter really can't be relied upon for signifying that a patient is alive. There are some, I try to find another example of this. It was mostly things that we kind of played with in vet school, but here is, one image of a pulse oximeter that's showing a heart rate of 33 beats per minute on this banana. And, I really hope that that's not true for the sake of anyone who's a vegetarian. The banana is not alive, but more importantly, what this, is highlighting is that there is a flaw in this technology. And so sometimes it allows artifacts to be shown as, an actual heart rate. And so it really is important to not kind of rely on a pulse oximeter as a sign of life. Errors and artifacts can occur with light and motion and electrical interference. The range of accuracy on these pulse oximeters is usually between 100 and 76%. So if it's below 76, probably a blood gas is better the way to go. Hopefully not. This is not a frequent occurrence. Obviously, if even 76 is not good, but basically anything below that is probably not realistic. These units may not read well with poor perfusion or low perfusion. And it should also be said that, unless using a co-oximeter, there will not necessarily be a correlation to actual oxygen delivery with most pulse oximeters. Anemia is one clear-cut example where you can have certainly, 100% oxygen saturation of that hemoglobin, but if you don't have adequate red cells to carry all of that oxygen that's necessary, that patient may not necessarily have enough, circulating oxygen to reach the tissues. So those are some things to consider. All right. With ventilation, monitoring is primarily through measurement of your end-tidal carbon dioxide. And this is a non-invasive, simple attachment that can be put onto the patient end of the endotracheal tube. It provides confirmation of correct tube placement in the trachea and adequacy of that patient's ventilation. The production of CO2 really is directly related to systemic perfusion and cellular metabolism. So that is also true with body temperature. So as body temperature rises, metabolism tends to rise. Your end-tidal CO2 typically will also rise with things like that. So it's basically, your direct clue to cellular metabolism. End-tidal CO2 can also be used as a marker for the effectiveness of CPR. The waveform that is produced by a capnogram allows you to rapidly detect any disconnection, obstruction, or help warn you of impending cardiac arrest. There are two types of sensors for CO2 monitoring, and one of those is the mainstream sensor. Mainstream units look somewhat similar to that. They measure directly at the sample site. So it may be bulky for small patients, which, it could be quite a heavy unit that's sitting on there, but there is no delay in the measurement. It takes it right away. May increase the mechanical dead space as well for small patients. The EMMA is this portable unit that is kind of in this lime green color shown there. And those are kind of standalone units that operate on a battery, and they're useful for patient transport as well. There's one in action, and it just hooks up right to the end of the patient endotracheal tube. And you can, travel with that animal around the hospital. If the mainstream capnograph is connected to a multi-monitor, usually there is an additional approximately $2,000 kind of attachment for this unit on the machine. Probably more if you want to be able to measure other inhalant gases as well, but CO2 is probably the most useful on a general basis. The other type of sensor is called a side stream sensor, and so this draws gas from the patient circuit, and it's measured at a distant site. So it's usually measured at the base of the monitor. Since it removes gas from the circuit, it does require scavenging in the base unit. And you do have to ensure that you replace the fresh gas flow that's removed from it. So if you have a super tiny patient, usually these draw gas anywhere from 50 to 150 mils per minute away from the patient circuit. So if you do things like low flow anesthesia, then you just have to account for the fact that, these side stream monitors may be taking gas from the patient circuit out. There is a slight delay in this reading because it depends on the length of the tube that it has to travel to the machine. And so it won't pick up end-tidal CO2 readings right away. They can be attached directly to the end-tidal tube adapter. And so the side stream is probably something that results in the least amount of dead space for a small patient. But those lines can become kinked or obstructed by water or secretions. And so if you have issues with the waveform or the reading, troubleshooting that capnograph line is often something that you have to start with. The costs of the side stream is pretty similar to the mainstream. Capnograph waveforms are a very useful tool for monitoring, and although we unfortunately can't go through waveform analysis in the scope of this presentation, there may be good websites to peruse to look at these different waveforms and just get a sense of all of the possible patterns and things that you can pick up on by using capnography. Temperature monitoring is next, and most multi-parameter monitors do include at least one temperature probe. They are typically placed rectally or esophageally, and these locations help us obtain kind of a near core body temperature on these animals. We can also place temperature monitoring equipment in the axillary space, oral, pharyngeal temperatures with usually just handheld devices. There are three basic types of thermometer technology, and this qualifies for veterinary and non-veterinary units. The first is an equilibrium thermometer, and this is the most basic. So this thermometer is in contact with the body and it reads continuously. So it tries to equilibrate with whatever space it's touching. And, it takes probably the most time to actually generate a reading. So these are our indwelling probes. These are mercury thermometers. These are things that have to take, kind of a long time to give you a measurement. Another is predictive, and these are also contact readers, but they detect the rate of change in temperature. And so these go much faster, but they're not a continuous reading. They're kind of, you press the button, it gives you a 3-second read, and then that's, what it's predicting that animal's body temperature is going to be. Last is infrared, which we are probably all super familiar with now over the past year. We've all been laser temperatured everywhere we go. So these are non-contact thermometers, and they only detect the radiant heat from the surface of an object. They're not reliable for getting an actual core body temperature, but they can help you kind of notice trends. I would say that this probably has very little utility in vet med, but it's something that somebody may try to sell you, or you may see out there in the conferences when we eventually go to vendor things again. So temperatures can vary depending on where the probe is placed and as well as what procedure is happening. There are a few studies in animals that are under anesthesia. This one happens to be in awake animals because it was just very extensive as far as what sites they were going to, and it was both dogs and cats. So in most terms, the difference in temperature between sites is pretty inaccurate in terms of a core body temperature. So your axillary temperature is generally going to be about a degree less than rectal in dogs, a little bit closer to rectal in cats. So as a standalone number, as saying that is a body temperature, is not fairly accurate, but you can use that number as a baseline and then, try to follow that trend, because obviously most of the time under anesthesia, patients are losing heat. So you can kind of gauge how much heat loss they are experiencing. In this particular study, they did not evaluate sedated or anesthetized animals. But that may be something that comes about in the next few months or within near future. In anesthetized humans, the most reliable and accurate sites for placement of temperature probes are the distal esophagus, the tympanic membrane, the nasopharynx, and the pulmonary artery. The temperature of the blood in the pulmonary artery is just considered to be, that is the definition of core body temperature. Obviously, that is highly invasive. It's not clinically practical at all. So we attempt to use other sites that will, give us the best approximation of that temperature. But pulmonary artery is considered gold standard. So that's what everybody compares everything else to. In cats, the tympanic membrane was not particularly accurate versus the esophageal or rectal temperatures. And so, so that was kind of found to be not terribly useful for us in that situation. One of the reasons that we also, are trying to, find better locations for temperature probes to go is that often, we consider the temperature probe to be a pretty benign thing to have, but it actually can lead to complications. One of which could be that often that temperature probe ends up going down the trachea instead of the esophagus. And so we do have documented occurrences where that temperature probe can actually wrap around the tube, get stuck through the Murphy eye. You would think it would not go down that way because there's another tube down there, but unfortunately it doesn't. And there have been several instances where a temperature probe will actually go down the trachea. And so, so kind of making sure it goes down esophageally is actually more difficult than it should seem. But it can happen. And so these complications have prompted us to try to look at the skin surface as another place to, attempt to get accurate readings. And, this kind of eliminates the possibility of, causing trauma or damage or anything to these animals. Anesthetic drugs, especially inhalants, they do induce vasodilation. And so this results in, greater heat loss from the skin surface. They don't do the normal, cold response where you vasoconstrict and you save your heat for the core. So because they are losing heat through the skin surface, the surface temperature gets a lot closer to the core body temperature. And so in these cases, you may be able to use the axillary temperature as a reasonable estimate of core body temperature minus about probably, 1 or 2 degrees. So we'll often take an axillary temperature, say, okay, if it's 98 at the axilla, then, it's probably about, 99 to 100 or so for a core body temperature. This may be a useful thing to use as things progress, or if there is not the possibility of putting an esophageal probe or a rectal probe down to obtain a core body temperature. All right, and with that, hopefully I finished just in time. So are there any questions? You guys can, pop some questions in the chat box, and I will be able to answer them.
Okay, I have a question for you, Dr. Dholakia.
Sure.
Do you recommend using both alcohol and ultrasound gel with your Doppler probes?
Typically when I apply it, I will just stick with gel. Haven't normally had to use too much alcohol on there. And for most of the procedures, I find that the alcohol just really evaporates so quickly that the gel tends to, by itself, it'll kind of form a little, pocket, I guess, under the tape and attached to the probe.
All right.
But whatever works for everybody.
All right, next one. I've heard that alcohol can damage the piezoelectric crystal. Is that true?
Yes. Yes, we unfortunately ran into that issue a lot because people had good intentions. They wanted to clean the probe, Alcohol was the easiest thing to go with, and we were finding that it does damage the epoxy, and it probably does damage the crystals eventually. So it was causing a lot of issues, and eventually we had called the company, and we were asking them, why are all of our probes going bad so quickly? And they, right away they said, don't use alcohol, don't use, very powerful cleaning products on it. And so we had to come up with a new system and kind of tell all of the students and people who were passing through, and just wipe it off. Don't use any alcohol. That was a good question. Yep.
Next question. Do
Okay.
people really check lactate intra-op?
I mean, I do. It really depends on the case. I think that there are small point of care lactate meters, and so they're not difficult to run. You only need like the tiniest drop of blood. It's very fast. It's as fast as a glucometer. And so that is something that it's just, it's so fast and easy to run that if you do have that point of care, obviously, if you're trying to run it in a panel, with a more, elaborate, blood sampling machine, ClinPath machine or something like that, it's not easy. But if you have a small point of care lactate meter, it is very fast. And that's one of the things that, again, you do have to take a baseline lactate prior to anesthesia to compare it to, because it will change, even based on, just being unanesthetized to anesthetized. But it's come in handy in a pinch, because there's some animals that you just cannot get any kind of a reading anywhere. And I'm talking, these were horrific, morbidly obese pugs that were having, abdominal explores and things. And, there was not even a leg to put an art line in, nothing is reading. And so it's certainly come in handy in a pinch where I just said, I have no information I'm going off of. I would like to know what's happening with this patient. Am I doing anything for it? And so sometimes it does help.
All right, next question.
Yeah.
Are blood pressure cuffs better on front legs?
Not necessarily. Most of the, most of the time we are placing them where we have a cuff that most appropriately fits that kind of 40% of the circumference, of the leg best. And so most of the companies that produce these cuffs, they, occasionally there's a size jump that makes absolutely no sense to me, but they're, that's the shape and size of the cuff. And so usually I will use whatever leg best corresponds to, fit that size cuff. And so, so I have not noticed a difference between front or back. Typically, they do tend to work better either between the elbow and the carpus, or above the tarsus if you use the hind leg. There are a lot of occasions where people will try kind of low down on the wrist and, below the tarsus, but sometimes they work, sometimes they do work there, but occasionally the greater accuracy is usually found above those joints. So whichever leg it's on, usually I'll try above the joint beforehand.
All right. Allison asks, what is your favorite thermoregulatory device? Her, it's the bear hugger.
There have been, many, many occasions of shopping around on a lot of these thermal devices. So I would say that, a combination of things seems to work the best. What I've used in the past have been that we've put, there are these units called hot dog blankets. And so those hot dog warmers, usually on the table, have actually worked better than I, anticipated they would. But we had them at my residency, and they work very well. You do only have to use the medium setting, because the high setting is a bit too hot unless you have good insulation between the animal and the pad. But those worked amazingly well. And so that in combination with a bear hugger typically kept our patients, they were insulated and they came out, most of the time they came out quite warm. And so I was impressed with kind of the combined hot dog bear hugger. Again, not promoting anybody, but that was the closest I've gotten to keeping a patient, normothermic during, very long procedures. Sometimes it really does depend on the surgery, though. I mean, if they're, open with a really large abdominal incision, sometimes whatever we do just doesn't make a difference. But those two things have tended to be quite well. There is unfortunately some degree of perceived increase in orthopedic infection rates with forced air warming devices. So for bear huggers, they have started to recommend that you only turn them on after the patient has been fully draped in, and, to limit all of that kind of air blowing around. And I guess, I don't know if they're suspecting that there's, hair blowing or dust blowing or something is blowing into those orthopedic incisions. And so that's something that in recent years, they have detected in human medicine as well as veterinary medicine, where it's just for these orthopedic procedures, they do prefer that the bear hugger not be turned on until the patient is fully draped in, which unfortunately means that prep has got to be really fast and, don't spend too much time doing a lot of pre-setup, get that patient draped in so we can get it warm and warmed up.
Okay. All right. We've got a lot of questions, so I'll keep rolling.
Oh, great.
Is there any difference in accuracy of mainstream versus side stream CO2 monitoring?
On a patient basis, they should be fairly similar, but I would say that if there's a difference in accuracy, it may depend on if they're using a non-rebreathing circuit or a circle system or anything like that. But probably the mainstream, I guess, ideally may be more accurate because it really is sensing it right at the patient end of the endotracheal tube. There are a lot of things that can happen to that side stream line. And so in theory, since it has to travel and it has to go to the machine, I would say that, there is a chance that the mainstream is probably more accurate. And it's a little bit more real time. So, it's going to be literally that breath that it's reading at the same time. Whereas the side stream has a little bit of a delay. So you don't know, like, hey, was that 2 breaths ago? Was that 3 breaths ago? But a good machine should be able to still, provide you with a reasonable number.
Now, switching gears, similar to a previous question about cleaning, what is appropriate to clean a pulse ox probe?
I would say that most of the time, we're only cleaning them with, a little bit of just like probably just, tap water on a small piece of gauze or something. So usually, a little bit of blood spills on it or something. They're not, hopefully they're not going in places that are too, requiring to be too sterile. Obviously, we want to keep them clean and working well, but most of the time, yeah, harsh chemicals, alcohols, everything does affect the sensor. Most of the time, the company has been recommending, non-lint, but non-scratching type of materials. And so personally, I think what I've just been doing is, a small amount of warm tap water to get everything off of it with a very soft piece of gauze. And that seems to do the trick for the most part without damaging any of the probes or pieces.
Now, what are your favorite pulse ox probe adapters, and what's the most reliable placement for those on the patient?
A personal favorite, because we do see so many patients that have pigment issues, and there's a lot of motion artifacts and things in there. So a lot of the time, what seems to have worked the best is there are transreflectance probes that are called, kind of forehead probe. And so some of those are just flat-faced probes that basically have the two lights are, or the two sensors rather, are on the same side. And so in an animal that has, pigment everywhere and you can't get anything to work, those actually work quite well, where you can shave the base of the tail and place the sensor just flat side up right under the base of the tail where there's an artery. And that has read beautifully. It reads quite beautifully all the time. Doesn't matter what color the animal is or that its mucous membranes are always, just darkly pigmented, and so you can't get anything to work any there. It also doesn't get subject to motion artifacts and things. And obviously when the patient is recovering and waking up, especially these, animals that you need to really monitor their oxygenation closely as they're recovering, like let's say, your brachycephalics or things that are having thoracotomies, or any instance where you really need that oxygenation. The clip probes just never seem to work right when that patient is waking up, and that's when you need it to work the most. So these flat-faced probes, there are some companies that also produce probes that are like pediatric sticky finger things. And so those also have the ability to, stick to the base of a tail or something like that. So I would say probably the transreflectance probes that come in a variety of shapes and just kind of sticky applications, or flat probes that you can get will work any other part of the body other than the face and the mouth, which really comes in handy when you can't get to that part of the animal.
Okay. Now this one's kind of fun, designed to keep you on your toes. All right.
Okay.
You're on a desert island, and
Ooh.
you're running an anesthetic case, grade 2 ASA. Your multi-parameter machine is at the bottom of the ocean.
Oh no.
What two devices would give you the best information?
I would go with, I would want an Emma in that situation. So, yeah, in the absence of any other piece of monitoring, I think an end-tidal CO2 is really something amazing, because with that end-tidal CO2, you know that animal's alive, it's breathing, and you get, again, as kind of a very relative sense that